Good afternoon. Welcome back to Grand Rounds today. Please remember to sign the attendance record at the back of the auditorium, and also please remember to fill out and return the program evaluations. And as I always do, I'll ask you to give us any ideas in regards to future topics and future speakers that you'd like to hear. Today, it's my great pleasure to actually reintroduce Dr. Scott Vogelgesang. Dr. Vogelgesang is a professor at the University of Iowa College of Medicine in the Department of Rheumatology. He's also the director of the Division of Immunology, and we're very, very pleased that he was able to accept our invitation today to come over from Iowa City and update us on some Rheumatology Pearls. So please join me in welcoming Dr. Scott Vogelgesang.
Thanks. I'm happy to be back here. It's always fun to come to Ames. It's such a pretty city, and I saw in the paper that the Cyhawk series now is extended 2 more years. So apparently that's a good thing. This is a big auditorium. I really like it here. And the microphone's loud enough. Everybody can hear me? Okay. So give me an idea of who's in the audience. I know we have at least one rheumatologist. Who else? Do we have physicians? Raise your hands for me. Okay, what specialties? Okay. Pathology? Okay. All right, nurses? Okay, in what areas? Okay, anything else? ARNPs, PAs? Anybody I forgot? Okay, all right. So, my goal today is to do a rheumatology potpourri, and specifically to talk a little bit about osteoarthritis. And so what I decided to do was focus on things that I think non-rheumatologists need to know, and it's really going to be case-based. And so what I'm going to try and do is make this as interactive as possible. You'll see me stop several times, and it's more fun for me if it's interactive. So if you have questions, just stop me. So 73-year-old woman has had shoulder pain for the last 3 months. It's been getting worse. She has no precipitating event. She can't sleep because of the pain, and she hates to move her shoulders. She has difficulty getting dressed, and she notes that she's stiff in the morning, and it lasts about an hour. On review of symptoms, she denies fever, chest pain, shortness of breath, headache, jaw pain, scalp tenderness, changes in vision, or swollen joints. Her family social history is unremarkable. Her medications include only aspirin. Physical exam, her vital signs are normal, and she's pretty uncomfortable sitting there. She has really limited shoulder range of motion, but the rest of her physical exam was normal. Her CBC was normal, chemistries were normal, and her SED rate was normal at 17. So my question for you is, what's her diagnosis? And then how are you going to evaluate her further and treat her? So what do you think? Shout it out. I heard a little bit. Say it again. Get an x-ray of her shoulders. Okay. What do you think she's got? Osteoarthritis, is that what you're thinking? So at 73, she probably does have osteoarthritis in her shoulders, but it shouldn't cause her stiffness to last an hour in the morning, which sounds inflammatory to me. So I'll tell you right now that her x-rays of her shoulders show some degenerative change, but she's got it in her hips and she's got it in her hands, and that's probably not what's causing her pain. What else? Say it again. You can charge it. PMR. So this is something that suggests PMR, and so the classic presentation would be somebody who has shoulder and neck pain, maybe hip and thigh pain. And so what about the age range? What do you think about that? Does that fit pretty well? So the answer is yes. More commonly, it's somebody who's older. By definition, it has to be somebody who's older than 50. Almost everybody's older than 60, and actually the average age of onset is about 70. And so it's more common in women than in men. So this story fits pretty well. She's not really telling us about neck pain. She's not really talking about hip and shoulder pain. And if this is PMR, how are we going to treat her? Does anybody know? Prednisone. And so high dose or low dose? What do you think? Yeah, low dose works pretty well. What doesn't fit very well in this case presentation with PMR? There's one thing that doesn't fit. SED rate. And so the SED rate doesn't fit very well. And so SED rates, I just want to take a little bit and talk about this. SED rates are non-specific markers of inflammation, so they go up with inflammation, they come down when the inflammation stops, but they can be independent of inflammation as well. And things that cause elevations in SED rates in the absence of inflammation include pregnancy, obesity, especially in women, hypergammaglobulinemia, and they go up with age as well. They also go up a little bit in anemia. C-reactive proteins are another acute phase reactant that come up quickly with inflammation, fall quickly. C-reactive proteins are faster than SED rates. SED rates come up and down over a period of days to a week or longer. C-reactive proteins can go up and down within a day. And then there's something that we're starting to recognize more and more and more. Obesity and diabetes can be associated with mild to moderate elevations of CRP and SED rates. And so that can be confusing sometimes. And I may have a case, I can't remember. Yep, here's an example. 35-year-old woman presents to the clinic with diffuse musculoskeletal pain for years. She hurts all over. She sleeps poorly, wakens feeling tired. Her spouse says that she has really loud snoring. Past medical history, she has diabetes type 2. On exam, her vital signs are normal. Her BMI is 40. She has fibromyalgia tender points, which are extremely tender. And the rest of her exam is normal. Her CBC chemistry panel, urinalysis, TSH, vitamin D are all normal. Her SED rate is elevated at 35. Her CRP is elevated at 1.5 milligrams per deciliter. And the question is, does she have an inflammatory disease, and does she require a rheumatologist and or prednisone? So, what do you think? Does she have an inflammatory disease? I'm seeing one person shake their head no. So, does she need a rheumatologist? We won't see her. And does she need prednisone? Probably not. And so the answer is, yeah, she probably does have an inflammatory disease, and it's called obesity and diabetes. And so what's being recognized now is that adipocytes now make interleukin-6, and there is this inflammatory reaction that will cause things to go up. Does she need a rheumatologist? No. She probably has sleep apnea. She probably has... well, we know she has diabetes and she has fibromyalgia. Does she need prednisone? No. And so going back to the first case that I talked about, the diagnosis was in fact polymyalgia rheumatica. She was started on prednisone 15 milligrams a day, and she had 100% resolution of her pain within 12 hours. And in fact, this particular lady had resolution within about an hour and a half. She left the university clinic, took her prednisone on the way out to the mall because her daughters were going to go shopping. And about halfway around the mall, she got up and walked out of her wheelchair and said hallelujah. And oh, by the way, her C-reactive protein returned at 2.3 milligrams per deciliter. And the literature will say that in polymyalgia rheumatica and giant cell arteritis, about 5% will have normal SED rates and normal CRPs. Okay, questions about that case? About SED rates, CRPs, PMR? Silence. Yeah. Yeah, so the question is, what about the difference between low dose versus high dose? And the point that he's trying to make, which is appropriate, is that if you give people more than about 20 milligrams of prednisone, there's a euphoric effect of prednisone, and people feel much better. So you take somebody with osteoarthritis and give them 60 milligrams of prednisone, they feel better for a while. That's why, particularly for something like polymyalgia rheumatica, I like to use a lower dose, lower than 20. So my favorite dose is about 15, because if they get better, that's probably because we're treating inflammation, as opposed to if I give them 20 and they get better. I can't tell if that's just the euphoria of prednisone. Did you want to add anything to that? Okay. Okay. Anybody know what Iowa's oldest city is? I heard Dubuque. Anybody else? Keokuk? Anybody else? Not Ames? No one said Ames? So Dubuque is correct. I didn't know that, actually. Let's see if my link works. So I didn't know. Nice pictures. Although I don't know. Anybody know when it was founded? Okay. Next case. 27-year-old woman complains of pain and stiffness in the joints and muscles for the last 6 months. She has morning stiffness that lasts 2 hours. She has swelling of her hands. Ibuprofen 800 milligrams 3 times a day doesn't help. She's been reading on the internet and believes she has lupus. So she shared the concern with the doctor at her office, who ordered an ANA, which returned positive at 1 to 80 and speckled. When you go through her review of symptoms, she has oral ulcers, joint pain, fatigue, chest pain that worsens with coughing or deep breathing, photophobia, and the rest is all negative. Her family history is negative. She doesn't use tobacco, doesn't use alcohol, and she works as a secretary in a dermatologist's office. Her medications include oral contraceptive pills. Her physical exam, her vital signs are normal. She looks a little anxious, but she has no joint swelling with full range of motion, and the rest is negative. CBC, chemistry panel, and urinalysis are normal. So the big question she wants to know is, does she have lupus? What do you think? Okay, I'll make everybody commit. How many say yes? Raise your hand. How many say no? How many didn't vote? Yeah. Okay, so here's the lupus criteria here. We use a mnemonic. Not everybody likes mnemonics, but there are 11 criteria here. And how many does she have? So maybe oral ulcers. She has chest pain that worsens with coughing or deep breathing, so it makes you wonder about serositis. The thing that's interesting is a lot of patients that I see tell me about photophobia, and they come in with sunglasses, but that's not actually part of the criteria. It's actually photosensitivity. It's when they get into UV light do they develop a rash. And she has a positive ANA. So how many criteria does she have, maybe? So she's got oral ulcers, maybe serositis, maybe ANA, and the photophobia doesn't fit. So she's got 3, and she's teasing us with the photophobia. So she's sort of in between there. So that gave me the vehicle to talk about ANA. So ANA stands for anti-nuclear antibodies, and we associate that test with lupus, and that was actually what it was designed for. And in fact, at least 90, 95, some will say as high as 98% of people with lupus will have positive ANAs. The problem is this bottom statistic here, which is, depending on the titer, up to a third of the general population can have a positive ANA. So it's really a very non-specific test. So the question is, who should have an ANA checked? And the answer is those who you believe have a systemic autoimmune disease based on your clinical findings. And clinical findings is really the key. Oftentimes, ANA gets used as a screen for autoimmune disease, and the problem is when you do that, most of those are going to be false positives, and I'll show you that in a minute. So at the end of the presentation, do you all have handouts, by the way? Okay, at the end of the handout, there's an article there by Volkman. And she talks about how to use ANAs. And one of the things that she identifies are 3 things here as looking for ANAs is if somebody has Raynaud's, if you actually see joint swelling, or if they're on high-risk drugs. Hydralazine is a classic one. or if they have other features of systemic autoimmune disease, so features of lupus or Sjogren's syndrome or scleroderma. Oop, let me go back. A little too fast. Now, there's another paper in there that looks at when ANAs are used as a screen for autoimmune disease. And so somebody comes in with ill-defined symptoms, and the arthritis panel gets sent off, which has an ANA, rheumatoid factor, CCP, SED rates, CRP, uric acid. And when you order that many tests, one's going to come back positive by chance alone. When those referrals, this is a paper that looked at it, and they had 232 patients who were referred to a rheumatology office. More than 90% had no ANA-associated disease, so the majority of those were false positives. And so the problem is that the ANA has a poor predictive value. And then going back to the Volkmann article, the interesting thing is she has a nice little algorithm about what to do with somebody who has a positive ANA. And I won't walk you through all of this, but I would encourage you that if you're taking care of somebody and you have a positive ANA, but it doesn't seem to fit with anything that looks like lupus or scleroderma or Sjogren's syndrome, this article will give you an algorithm that you can work your way through it. So if we go back to our original case, how many does she have? She has 3. She had the photophobia, which actually isn't part of the criteria. And oh yeah, I forgot to tell you that she had tender points. So what she really has is fibromyalgia. And the problem with the lupus criteria is that oral ulcers, canker sores, are pretty common. How many in this room have ever had a canker sore? Yeah, see, that's the problem. It's a criteria, but it's a soft criteria. And we were talking about, over the weekend, I was doing chores for my wife, and I was lifting a railroad tie, and I can tell you that after I was done with that, I had musculoskeletal chest pain that hurt when I coughed or took a deep breath. So that is actually relatively common, and again, unfortunately, ANAs are fairly common. So the dreaded question then at the end of this evaluation is, Dr. Vogelgesang, are you 100% certain I don't have lupus? Well, I'm not 100% certain about anything, particularly in medicine. And so there's a couple more articles down here that are useful. The first one came from the 70s, and it came from Finland. And the nice thing was they have government-sponsored health insurance. And so if a woman wants the government to help with health care when they get pregnant, they get seen in the health clinic, and they had a serum bank. So what they did was they looked at women who had positive ANAs but had an otherwise normal exam and otherwise normal laboratory tests. And the question was, then they were able to go look 10 years later to see how many had actually developed lupus. And the answer was less than 1%. So for this particular lady, am I 100% certain she doesn't have lupus? No, but I'm 99% certain. And those are pretty good odds. The paper down a little bit lower looked at somebody who had a high titer ANA, which is 1 to 640 or higher. And interestingly enough, with a normal exam, normal laboratory tests, and a high titer positive ANA, less than 10% of those went on to develop lupus. So ANA is really a lousy test. Rheumatology tests lie to us all the time, unfortunately. Okay, questions? Anything you want to add to that? Yeah. So the question is, what's the difference between the immunofluorescent test and the ELISA? So the test was developed as an immunofluorescent test, and most of our data is based on that. But there were a couple of labs across the country, I don't know, 10, 15, 20 years ago, that found out that you could do an ANA with an ELISA, and you can do 100 at a time. It's cheaper, it's faster, and you can turn it around much quicker. And we were all waiting to see how the sensitivity and specificity was going to work. And it turned out that the sensitivity with the ELISA was lower, but the specificity was no higher. So it turns out that the ELISA test is worse in terms of how it performs. But for a commercial lab, that's what they at least some of them, choose because it's a lot cheaper, a lot faster to use. So the actual recommendation is if you're going to screen somebody, if you're suspicious for a systemic autoimmune disease, you should probably do the indirect immunofluorescence test. Now, there are some very well-known immunopath labs, one of which is a little north of here, that consistently does ELISAs. And so the only problem with that is if we do an immunofluorescent ANA and it's negative, you can virtually exclude lupus as a diagnosis. With the ELISA tests, it's not necessarily true. Do you want to add anything to that? Okay. Any other questions? Where are our lab people? Do you do ANAs here or do you send them out? Send them to Mayo? So then probably it's ELISAs that you're seeing, right? Not the indirect immunofluorescence? Do you know? Yeah, okay. Anybody know the answer to this? What's the deepest natural lake in Iowa? West, east? I heard one west. Anybody know how deep it is? West Okoboji. Its depth is 136 feet. You know, up until about 3-4 months ago, I'd never been there. And so I wanted to see them, and they're beautiful areas. I think I'd like to have a place there. Okay. All right, urgent evaluation by rheumatology. So who should be seen by rheumatology quickly? So which diseases, which conditions? So there's pretty good data now that if people with rheumatoid arthritis and probably psoriatic arthritis get treated on immunosuppressive medications like methotrexate and others, they do better. So those are the kinds of people that we ought to see quickly. Also people with glomerulonephritis, pulmonary hemorrhage, mononeuritis multiplex, inflammatory CNS involvement. Monoarticular arthritis, particularly with a fever, is probably somebody that we could see, although those patients could be seen by our orthopedic colleagues too if you can't get in there. Patients that probably don't need to be seen quickly are people with a positive ANA only, a mildly elevated SED rate or CRP, fibromyalgia, and the more recent one is Ehlers-Danlos syndrome. And so what we've started to do, as was alluded to earlier, is now we're actively triaging patients that are coming into the clinic. So somebody with inflammatory arthritis, psoriasis, something that looks like lupus, something that looks like vasculitis, we fast track them into the clinic. People with laboratory tests that are positive that don't appear to have any coexistent physical findings or other laboratory abnormalities usually get triaged to the back of the list. So you will see us, at least at the university, doing that and talking to at least some of the rheumatologists in Des Moines. They're starting to do something similar. I wanted to talk a little bit about systemic autoimmune disease. And there's an important take-home point here. And so now I'm talking about vasculitis and lupus in particular. Sometimes we struggle, and rheumatologists love to argue about, is this polyarteritis nodosa or is this microscopic polyangiitis? But it took me a long time to figure out that it doesn't really matter. And what I mean by that is the name, at least right now, doesn't matter so much. What matters is which organ system is affected and how severely. So consider a 52-year-old woman admitted to the ICU with respiratory failure after presenting with hemoptysis found to have a creatinine of 4.8 and a urinalysis with 2+ protein and 25 red cells with red cell CAS. What's her diagnosis? Well, we can put together a differential, right? But she's sick. And she needs to be seen by a lot of people. Pulmonologists, nephrologists, probably rheumatologists, maybe hematologists. Even though we don't know what she has, it's pretty clear that she needs to be seen pretty quickly. As opposed to the second one, 37-year-old woman with known lupus who presents with joint pain but doesn't have any swelling, has a little bit of mild malar erythema, found to have a normal CBC, normal creatinine and urinalysis. Does she require urgent evaluation? Probably not. She has that label of lupus, but her major organ manifestation right now is, musculoskeletal pain, a little bit of rash, And so she probably doesn't need to be seen very quickly. So the important thing is which organ system is affected and how severely. And so oftentimes when I get a referral, somebody will say, well, I think this patient has Wegener's granulomatosis and the ANCA is, and I'll say, wait. Tell me about what you found on exam. Tell me about what the creatinine looks like. Tell me about what the UA looks like, and so on and so forth. Any questions about that? How are we doing for time? Okay. All right, so here's another Iowa trivia piece. The blank monument in which city honors the only man to die during the Lewis and Clark expedition? Sergeant Floyd. Impressive. Did anybody know that? Yeah. Oh, a couple of people. I had no idea. Sergeant Floyd Monument in Sioux City. And let's see if we can find it. There it is. Yeah, right. I didn't know. I need to brush up on my history, clearly. Was he the only one who died in the whole expedition? Really? Oh, I see. I'm learning something every day. Okay. I've got another case for you. 67-year-old man has severe osteoarthritis of both of his knees. He lives in a 2-story house with a bedroom on the 2nd floor. He's sleeping on his couch because he can no longer climb the stairs, and he's seen an orthopedic surgeon, and total joint arthroplasty is felt to be appropriate, but he wants to wait. And so for the pain, he's used, with moderate success, acetaminophen 1,000 milligrams 3 times a day, ibuprofen 800 milligrams 3 times a day, and then topical diclofenac, a nonsteroidal, twice daily. And he comes in and says, what else can I do short of surgery to control the symptoms and to be able to function normally? So, with osteoarthritis, the non-pharmacologic wing is education, talking about exercise and rest, talking about weight loss, talking about ambulatory aids, canes, walkers, things like that. It's interesting that my mother, who is 83, was having trouble with balance, particularly in the wintertime in Minneapolis, going out to get her mail, and I was very nervous about this. So I wanted to get her a cane, and she responded with, oh my God, no, that's for old people. And I said, okay, how about we get you a walking stick from Walmart? And she thinks it's great. So she took off the rubber tip, and now she has, what are those things called? Yak tracks, those little crampon things. And she has them on her boots, and she walks out, and she looks like Nanook of the North, and she thinks it's really cool. Splints can help, and then we move into the pharmacologic piece. So far, no medication stops or reverses the disease process of osteoarthritis. There's a lot of interest in trying to find things that are working, and a lot of people looking at that. And so really right now the role of medications is to alleviate the symptoms and to increase function. And typically first-line agents are acetaminophen, nonsteroidals, and topical NSAIDs. And then surgery is indicated when you have severe pain that's unresponsive to medical therapy or a loss of joint function, like inability to be able to climb stairs. But this is a very busy slide, but I put it up on purpose, and then I also added it to the references at the back of the handout. I have to take off my glasses to see this. And this is from Nature Reviews of Osteoarthritis from 2016. And what they did was they looked to see what evidence there was out in the medical literature for all of these potential therapies for osteoarthritis. And there's a couple that I want to point to. So TENS surprised me because there's actually a fair amount of evidence suggesting that might help. Acupuncture. A little bit of evidence that maybe it helps. NR means, I can't remember, not something. NE is not evaluated. I can't remember what NR says. Maybe somebody who can see it a little bit better. Thermopathy, hot packs or spas. had actually a fair amount of sort of plus-minus evidence. And then nutraceuticals, and particularly the one that people are interested in is glucosamine. And there was one set of criteria from Europe that said, yes, it's probably worthwhile, but the rest of the recommendations and the rest of the evidence was pretty negative, which kind of surprised me a little bit. And the other one that's kind of gone in and come out of favor again is the intra-articular hyaluronic acid. Some of the guidelines suggest that there's some benefit. ACR has some conditional, the American College of Rheumatology has some conditional recommendations for using it. But the evidence out in the literature is actually not all that great. And so what I would encourage you to do is go back and take a look at this particular paper. And if you don't look at anything else, look at this particular table, because what it does is it tries to summarize what evidence is out there for osteoarthritis. And since osteoarthritis is so common, this seems to show up almost everywhere in the medical center. Any questions about osteoarthritis? I think in particular you wanted to talk about this. Is there anything in particular that you wanted to? So there's actually a fair amount of data, I should look and see if it's even listed on there, that intra-articular steroids help. The people that benefit the most are people that have a little bit of warmth and a little bit of swelling, which makes sense because that indicates that there's a little more inflammation in there than what you might normally see, and those people are most likely to benefit. Other than that, there's not a good predictor of who's going to respond, and so most of the time what I'll do is try it, and if it only lasts a couple of days to a week or so, then maybe I'm not so excited about it in the future. But if they get 3 to 6 months of benefit from it, I'll do it again. Other questions about osteoarthritis? Duloxetine has pretty good data for pain control. The problem with it is that unless I explain it carefully, people take a dose or two, expect their knee pain to go away, and then throw it away because it's not working. If they understand that it's going to take several weeks to build up and it may help control their pain over a long period of time, I think there's pretty good data that suggests that it helps with all different kinds of chronic pain. Yeah. Yeah, so the question is, if there are lateral or medial deviations of joints, would I change? And it depends on how old the person is, and it depends on how heavy the person is. There are some suggestions for different surgical techniques, particularly osteotomies, that sometimes I see the orthopedists use and sometimes I don't. Were you going any place in particular with that? Right. Yeah, that's true. The stronger that people are when they get joint replacement surgery, the better that they do. I was down in the basement this morning lifting some weights, and my wife said, why are you wasting your time? And my answer was, because I know I'm going to have to replace my shoulders, and the outcome's going to be better, and so I want my shoulders and my arms to be as strong as they can when I go to surgery. And she kind of looked at me and she said, yeah, whatever. Any other questions about osteoarthritis? Yeah. Yeah, so the question is about stem cell injections, and the other thing that's been looked at a lot is cartilage transplants. The data is small and not very well randomized. So far, the jury's out, and so everybody's watching to see what's going to happen. There's some a little bit of data that suggests that it may work in animal models, which is why it's probably being put into human trials, and I think we're going to have to wait. The problem is that most of the human trials take 10 to 20 to 30 years to actually see results. So it has promise. We went through this with doxycycline. So doxycycline in dog models helps to prevent osteoarthritis or prevent progression, but in the human trials it didn't work. And so we'll have to wait and see. Okay. Blank is Iowa's only town on an island. You got it. Sabula, which I'd never heard about. Have you been there? Well, don't know if my link's going to work. I guess there it is. Okay. So I actually think I've been there. So I don't know if you can see it. It is over. Okay. I can't show it to you. It's supposed to be really quite pretty. So, anybody see it? Over here, I think. There it is. There it is. Just east of Cedar Rapids, so not as far north as I was suspicious of. Anybody been there? Oh, you've been everywhere. Okay. Another. What's that? Oh, I got it. 63-year-old man. How are we doing for time? Good. 63-year-old man with a history of crystal-proven gout. He had joint aspiration that showed intracellular gout crystals, and he continues to have regular flares. So a flare is manifested by his big toe or his ankle or his knee swelling, and it's very painful and warm to the touch. His medications include allopurinol 300 milligrams a day. The examination shows a swollen, warm left ankle that's very tender to the touch. White blood cells were 10.8, creatinine is 0.9, and his serum uric acid is 8.0 milligrams per deciliter. So this is a pretty common scenario. So the question is, what should we do next? What does he need? Colchicine, that's a good first start because we got to shut off the attack. How about long-term therapy? Increase the allopurinol. And so there's been a lot of discussion lately about what to do with gout management, and the problem is that his uric acid's too high. We need it below 7, and ideally we'd like to have it below 6. And this has been somewhat controversial in the last year or two. And so the long-term goal for gout management is to lower the uric acid. So if they have tophi, if they have collections of uric acid crystals that you can see in the skin, we want to be able to push that your serum uric acid down to 5 milligrams per deciliter or lower. If they don't have tophi but they've had gout, we want to see it at least 6 or lower. And so in this particular patient, we might increase his allopurinol dose. We might double it up to 600 milligrams daily. Recheck a serum uric acid, CBC creatinine in 2 to 4 weeks. And in this case, colchicine or a nonsteroid will probably help him because he may flare in the meantime. The maximum dose for allopurinol is about 800 milligrams, so we can continue to push up the dose pretty clearly. And then febuxostat is the newer medication on the market, which now has a black box warning for cardiovascular events. And it's important that you know that because you're going to have to choose carefully who you're going to prescribe that for. The jury about cardiovascular events, and this actually came up at the symposium, is still out. Turns out that it may have something to do with how they did the study, and that allopurinol may actually turn out to have the same kind of risk, and nobody's really quite sure yet. And so the take-home message from this was be careful with febuxostat. It probably shouldn't be our first choice with patients with gout unless they've had some kind of an allergic reaction to allopurinol. Questions about gout, allopurinol, febuxostat? Yeah. Yeah, so the question is how long to put people on prophylactic colchicine and then how long to continue afterwards. So if you look at my gray hair, I learned in a time when we were supposed to start colchicine first and then add allopurinol later. And the idea was that you get the inflammation under control before you start to fool with the serum uric acid level. There was a paper that was done in the VA population about 10 years ago, 15 years ago, that said maybe we don't need to do that and you can start both at the same time. I'm not sure I completely believe that, but at least there's some data that supports that. And then the question to how long to continue, what you'll see in the guidelines is 6 months-ish. Now, I tend to push that, particularly if somebody's got tophi that are sort of everywhere, because it's going to take them a lot longer to equilibrate. There's some concern among people that study this a lot that long-term colchicine can be associated with some side effects, so they usually try and encourage us to get people off. So 6 months-ish is kind of what the guidelines will say, and then I might watch to see how people are doing. If they're still looking like they're trying to flare a little bit, I might go a little bit longer just to try and keep things controlled. Okay. Ripley's Believe It or Not has dubbed blank street located in which city the most crooked street in the world? Say it again. Muscatine and which? Snake Alley. Snake Alley is correct, but it's in Burlington. But I'm impressed. I didn't know any of this. And so, have you been there too? No? Next trip? So I'd never even heard of this. But there's a picture of Snake Alley. So I thought it would have been, what's the street in San Francisco? Is it Lombard? Yeah, I thought that was going to be the most crooked street, but apparently this is even more crooked. Of course, the judges could have been Iowan, I'm not sure. Okay. 1252. Okay, 67-year-old woman with long-standing rheumatoid arthritis is scheduled to undergo total knee replacement. The surgeon and the orthopedist want to know what to do perioperatively with the rheumatoid medications, which include etanercept 50 milligrams weekly, methotrexate 17.5 milligrams weekly, and hydroxychloroquine 300 milligrams daily. And so this shows up for surgeons and anesthesiologists and family physicians and general internists and rheumatologists. So what do you recommend? You see these patients all the time. We put them on these medications, they're having surgery, and then they come to you and say, what should I do? Okay? So, also in the references, an article by Susan Goodman, and there's some data for some of these medications and not much for others. Methotrexate has gone through a little bit of a change. Initially, they recommended that people stop it before surgery and restart it. Now, there's a little bit of data that says if you continue through, that people do a little bit better, and the idea is if you keep patients from flaring their rheumatoid arthritis when they're in a hospital, they do a little bit better. Hydroxychloroquine has such a long half-life that even if you stopped it for a couple of weeks before surgery, you're not really going to have an effect, so just continue it. And then etanercept, stop it. And so, again, from that particular article, there's a very nice table that's now become our recommendation for what we do. It's funny because one of my patients came in the other day and said, I'm going to see Dr. X in orthopedics, and what should I do with my medications? And my answer is whatever Dr. X wants. Because sometimes it doesn't matter how many times I show this table, they have an idea about what they want to see, and oftentimes it's stopping methotrexate. So this is a very nice paper that has a good table that gives you a reference about what to do with these kinds of patients when you see them. I think the other thing that comes up, and so here now the recommendation off that paper is stop etanercept 2 weeks before, restart it 2 weeks after. Methotrexate now we can continue, hydroxychloroquine we continue. One other big take-home message with people with rheumatoid arthritis is don't forget about checking cervical spine films, flexion and extension, because they can have erosions in the neck that the anesthesiologist is going to want to know about it before they manipulate that neck. And then at least think about whether or not this patient needs stress dose steroids. That has been controversial, I think, from the very beginning. Different groups have different recommendations. The other thing that comes up is what do you do with somebody who has etanercept, methotrexate, and hydroxychloroquine, and they develop a community-acquired pneumonia? And the answer is, if they look sick, stop it for a while, give them a chance to catch up, and then restart it again. Okay. So here are my summary take-home points. Rheumatology tests lie and mislead all the time. Order them to support a clinical impression, not to screen for inflammatory or autoimmune diseases, because you're going to find lots and lots of false positives. Rheumatoid arthritis and psoriatic arthritis should be seen quickly by rheumatology. If there is a suspected systemic autoimmune disease, the most important thing is which organ system is affected and how severely, and we get that information from history, physical exam, and basic labs. Gout, the goal is serum uric acid of less than or equal to 6 milligrams per deciliter, less than 5 if tophi are present. Perioperatively stop and restart disease-modifying agents and biologics based on the attached guidelines. And osteoarthritis, there's a ton of treatment options, some of which that are pharmacologic, some of which that are not. Questions? Yeah. Yeah, so the question is where to start with allopurinol, and the American College of Rheumatology and the European group recently put this into, well, I guess it was 2012, put it into recommendations. And so in most people, we're starting typically at 100 milligrams. Right before I was getting ready with this presentation, I was charting with a patient of mine, and he has a creatinine of 1.3, so with him I started at 50. And we'll probably go up really slowly. So usually the recommendations now are to start lower than what it was when I first started. So usually we're starting at 100 milligrams if they have normal renal function. If they have limited renal function, usually we'll start a little bit lower and go even slower yet. We'll recheck certainly serum uric acid, but usually I want to see CBC and creatinine at about 2 to 4 weeks, and then if they're not where I want them to be, then I turn up the allopurinol and keep going until I get them to the target that I want. Becomes a little problematic if I get up to 800 milligrams and they're still not where I want them to be. That can be a real problem. That's clearly a rheumatology case, because it's not clear how to manage those patients. Yeah? Yeah, so the question is, what's the role of diet? And a really strict diet can bring down serum uric acid by about 10 to 15%. So if somebody's at 7.5 and you bring it down by 15%, you can maybe get them down to that target. If you're seeing somebody who has a uric acid of 10 and you're really strict with their diet, you're still not going to get them down to the target. So diet's important, and it's important that they know what's in there, but you got to do typically more than that to get their uric acid down. Same thing with alcohol, the same effect. In fact, one of my colleagues at the university, historically, beer and alcohol in Europe in the Middle Ages was responsible, according to a lot of the history books, for the explosion of gout. There's actually data that says that maybe it wasn't alcohol, it was actually fructose. And so alcohol plays a big role, and it seems to push purines out into the system, which ends up in uric acid. And so yes, we try and get people to limit their diet, stay away from organ meats, shellfish, limit alcohol, all of that kind of stuff, and maybe that will help us with our medications, but usually it's not enough. Okay, thanks everybody.